Hello, my name is Amber Harris. I will be going through the abducent nerve. I just wanted to start off by introducing myself. You can see these are probably one of my three favorite photos because I really like hiking in Hawaii. And then I'm also in the military currently, and this is my dog, so just overload of cuteness. So the easiest way that I learned concepts is to picture them or put them in a way that I'm going to see them in real life. So the easiest way to do that here is do a clinical case study. So we're going to start off with a clinical case study where you're the provider and you see a patient in the emergency room. The symptoms that the patient is seeing is a double vision when looking to one side, headache, general pain around an eye. One eye is also cross-eyed. So upon receiving this patient, the first thing you decide to do is do a quick eye examination since clearly the symptoms are all doing with the eye. What you're going to do is have them do the 6 cardinal gazes, which is pretty much you take a pin light and you have the patient follow it with their eyes. So going up, going down, going from the bottom right to the upper left or the lower left to the upper right. After doing the quick eye exam, you notice that the patient, upon just looking at them, their eye is pulled in medially. You can see this on this picture. They have an inward gaze, which makes them seem kind of cross-eyed. And then the patient is unable to move the eye outwardly, especially when you take the pen light and go outwardly. And instead, they decide to accommodate that by moving their head instead, so they can't just move their eye. Really relates to the verse Proverbs 4:25 and 27, which key point here is let your eyes look straight ahead and fix your gaze directly before you. We could take this in the literal sense and try to make sure that our eyes are working properly and looking straight forward, or we can take it in the non-literal sense and just stay focused on the task we have at hand, putting God first, and really focusing on the purpose in which God has for us. After your examination, you deduct that it's sixth nerve palsy, or even called abducent nerve palsy or lateral rectus palsy. So how did you do it? How did you get that diagnosis? Well, now that you have the answer in front of you, sometimes the best thing to do is work backwards. So now we're going to go through all the information that leads us to our diagnosis, now that we know what the actual diagnosis is. So now we're going to talk about cranial nerves. Cranial nerves innervate or add power to the muscles and organs of sense in the thoracic and in the cranial cavity. Now, looking at this diagram, there's only 4 real cranial nerves out of the 12 that deal with eyes. And then one of them, the optic nerve, is only deals with sensory. And we're not talking about sensory, we're talking about motor. And so from there, and we look back at our case study, we see that the patient's eye couldn't go out laterally. So for us, now we have narrowed it down to the abducent nerve, and we're going to go way more in depth about the abducent nerve. What is the abducens nerve? The abducens nerve is the longest cranial nerve. Its pathway is quite long from the pons all the way to the lateral rectus. It's general somatic efferent, so it's only dealing with the motor and not the sensory. It is usually broken down to 4 or 5 components just due to its length: the nucleus, the cisternal, the cavernous sinus, and the orbital portion. And that's just pretty much describing the pathway it takes or the places it goes through. And also innervates the lateral rectus muscle of the eye. So we're going to talk about the anatomy, or pretty much the pathway that the abducent nerve takes. It actually starts in the pons, and I'm going to show you a different photo here. In this photo, you can see the inside of the pons, and this is the abducent nucleus. It's the beginning portion, and it runs down and out. You can see the facial nerve actually like wraps around it, causing this depression called the facial colliculus, and it's near the fourth ventricle. And so sometimes the fourth ventricle fills with excess cerebral spinal fluid, causing the abducent nerve not to work as well. So that's one of the things that affects the pathology of the abducent nerve, to just add. As the abducent nerve leaves the pons through the pons medulla junction, it actually runs in this area here, and there's an artery that runs through there, the anterior inferior cerebellar artery, that leads to pontine branches. And I'm just pointing that out because that's how the abducent nerve receives its blood supply. As it continues to go up along the clevis, which is just a bony part of the cranium at the skull base, it leads to the petrous part of the temporal bone. I'm going to show you a different picture that gives you a better picture of the petrous temporal bone cut, but it goes all the way up. Now, as it hits the top of this pretty much slope, there's a canal here, and it's called the Rollo's Canal. In the Rollo's Canal, there's, of course, the abducent nerve, but also the inferior petrosal sinus. And as it continues out, it hits a very important portion, and it's called the cavernous sinus. The cavernous sinus has a lot of cranial nerves in it, and it also has the internal carotid artery within it. And so I'm going to show you a picture of that. So this is the pretty much cross-section of the cavernous sinus, and you can see the internal carotid artery here. And then also you can see the abducent nerve. It has its own sheath, unlike all the rest of the cranial nerves. Cranial nerve 3, 4, and then part of the trigeminal, which is 5. So one thing to note is that the internal carotid artery runs really close. So if you have an aneurysm there, that also can affect that abducent nerve. And we'll talk a little bit more about that later. So we're going to keep on moving forward. As we get out of the cavernous sinus, we go into the superior orbital fissure. And that is pretty much our canal, or our route into the orbital, into the eye. And that's where you're going to see the annulus of Zinn, and then that's going to lead to the tendinous rings, and then to the lateral rectus, which is the muscle that the abducent nerve innervates. Now we'll talk about the lateral rectus. The lateral rectus is one of the muscles in the tendinous ring. The tendinous ring is all the muscles that move the eye. It's located on the lateral side. If you want to know how a muscle moves, you should try to make it as small as possible, because that's how it looks when it contracts. Now, when you contract the lateral rectus, it pulls the eye outward. So that's abduction, because adduction is adding to, and ABD, is adding outward. And the easiest way to remember this is the fact that the abducens, ABD, is the same as the abduction, ABD. So the abducent nerve innervates the lateral rectus that abducts the eye. Let's go back to our case study. Sixth cranial nerve palsy was our diagnosis, and the symptoms for it matches our clinical patient, right? So binocular horizontal diplopia is the same thing as double vision, except it's only in one eye. And then loss of eye abduction is also a symptom, and you know why? Because the sixth cranial nerve is the abducent nerve, and it abducts. Constant head turning movement is the compensation, of course, of not being able to abduct your eyes. And then there's also some minor symptoms like vision loss, headache, vomiting, and hearing loss. So let's talk about the causes of these symptoms. So lesions in any part of the abducent nerve, because it is really long, can cause compression of the abducent nerve. Therefore, the abducent nerve is not able to send the signals or send efficient signals to abduct the eye. Also, increased or decreased intracranial pressure also does the same thing. Also, you have to realize the lateral rectus muscle and the medial rectus muscle oppose each other, right? So if the medial rectus muscle is continuing to be contracted, then the lateral rectus muscle can't pull the eye outward. So that is also probably one of the reasons causes. Duane type 1 retraction syndrome causes strabismus, and that's just pretty much characterized by horizontal eye movement limitation. So pretty much it's just abnormal alignment of the eyes, which causes squinting. So that's how you did it. That's how you came to your diagnosis. Those causes and symptoms do match the clinical case. And then I hope you learned a lot about the abducent nerve. Have a great day.